All righty. So if y'all have any questions or anything, just send me a chat, or if I don't see it, just unmute your microphone so I can make sure I'm answering all questions. So good morning, and I hope y'all are doing well this week. Hopefully you've had a somewhat good week. I know it's not normal by any means, but as normal as we can get during these times. So today we're going to be talking a little bit about eating disorders. So eating disorders are pretty interesting. This is honestly probably one of the shorter lectures we're going to have. So we probably won't be here the whole 2 hours. So I know that should make you excited. But there are 3 main eating disorders that we talk about. So there's anorexia nervosa, which a lot of you have probably heard of before, okay? Bulimia nervosa, and then the last we're going to talk about, this is a new one in the DSM-5, binge eating disorder. And that one we'll touch on. I don't go in a lot of detail there because it is still a new disorder that is discussed, like I said, in the DSM-5. But I think a lot of us see binge eating disorder many of times in our nursing practice with people that are morbidly obese. Okay, so lots of things. Lots of times it's more the medical issues that are going on with those people as well. But now they now actually look at it and have decided in the DSM-5 that it is a psychological disorder, which I agree. I think it is. So just a few things. The National Eating Disorder Association, they say that eating disorders include extreme emotions, attitudes, behaviors, of course, surrounding weight and food issues. So I think that's something we don't always take into consideration, that eating disorders we think are usually, focused on food and weight, but it definitely has a lot of attitudes, behaviors, emotions, everything involved. It's not just, that's not the number one focus, if you will. Harvard Eating Disorder Center said eating disorders affect the mind and the body simultaneously. So same thing. I think it's something that we don't always think about. Also, one thing I just want to add before we get into etiology, unlike most mental illnesses that we've talked about, well, I say unlike most, really, this is the only eating disorder. Eating disorders are the only curable mental illness. Okay, so that's something to think about. So a little etiology, and I kind of talk about this at the beginning because it really goes with, for the most part, all of your eating disorders that we're going to discuss. Okay, of course, like I always say, etiology, of course, is unclear. There's definitely multiple theories out there. And it is probably a combination of all these factors involved. But they definitely say that serotonin plays a huge role. Serotonin pathways are usually abnormal. So they find that serotonin plays a big role there. Genetics as well. They find that, and we're going to talk about this when I go into the disorders as well. But female relatives are 12 times more likely of getting an eating disorder because of genetics. So that's pretty huge. Psychological. There's a lot of course, psychological stuff that they talk about with eating disorders. One of the theories I think is quite interesting that I've looked into some research and things about, they talk about how, somebody with anorexia nervosa, females usually don't get, or they have amenorrhea, which means that they are absence of menses for at least 3 months. So with this, there's a thought that a lot of times abuse happens or something has happened to the child, female or male, when they were younger in age. And this comes out when they are actually going through growth and development, because usually we find eating disorders happen around that time, like in the teens. And they actually have looked into things where they have like a fear of becoming sexual, if you will, you know, developing into their sexual organ, well, not really organs, but like, you know, where, of course, when things happen in growth and development, sexual wise. So, of course, ladies start to grow breast tissue and things of that nature. And the thought is this actually, the starvation actually kind of stops it in a way. So lots of times they don't get their menses at a reasonable time, and they don't develop breasts and things like that, like normal females their age. Okay. And it happens more with females. I don't want to say it doesn't happen with males, because it does, and we're going to talk about that. But of course, females is our larger population that suffers. Also, cultural considerations. Of course, eating disorders are seen more in Western women. More of the society ideal to be thin. So that's one thing as well. Also, other countries might self-impose weight loss to represent maybe their spiritual beliefs. So by fasting and things of that nature. So those are some other cultural aspects that we want to keep in mind. Let's see. All right. So we're going to start, of course, with anorexia nervosa. This is kind of one of the more common, that when you think of eating disorders, that is usually talked about or seen. So first, I want to note that anorexia, remember, actually means loss of appetite. Okay, this can apply to any patient. So I think a lot of times that we assume when we hear anorexia, that means anorexia nervosa, and we know that that is not true. Most of you have probably had a patient or two that actually has been diagnosed with anorexia, but it's not anorexia nervosa, which is the mental illness. Okay, anorexia just means loss of appetite. So of course we can see that in cancer patients, patients that are in a lot of pain and things of that nature. So I just want to point that out. The mental illness is called anorexia nervosa. All right. There are certain types, two major types that they talk about. And I'm going to try to break this down as best as possible, because I know there becomes confusion with, okay, well, what's the difference between anorexia nervosa and bulimia nervosa? And when we get to bulimia, I'm going to try to break that down a little bit better. Okay. So first, I just want us to focus on anorexia nervosa. So the two main types, there's binge eating and purging type, okay, and we'll get into that. And then there's the restricting type, okay. With the epidemiology for anorexia, they usually find that anorexia, the course is shorter. Most people that have it averages about 1.5 years long, okay. And I'm going to kind of come back full circle with that. So the 1.5 years long, I'll tell you why it's only usually 1.5 years long. They do find, of course, gender differences. Like I said earlier, they find that more than 90% of those with eating disorders are adolescent young women. And 5 to 15% of eating disorders are male. Okay. Also, to keep in mind, eating disorders have the highest death rate of any mental illness. So we don't always think of that, and I think that's really important for us to remember. So by saying that, with the anorexia, the reason it usually only it is a shorter course is because usually, hopefully, they get better or they die. There's no two ways about it. Someone with anorexia, it's very hard for them to live with anorexia nervosa for a longer period of time than that, because usually it's going to deplete the system and they're usually going to die, or hopefully they'll recover. Okay, and we'll talk about that. The mean age and onset, and I actually don't have my good outline at home, but for anorexia, they find usually that it's a little bit younger. Same thing, I'm not going to test y'all on this, okay? So bear with me. I don't have my book right beside me to look up what this book says, but usually the mean age of onset for anorexia, they usually find in the teens. So we're looking more like 16-ish, okay? It's usually younger adolescent women, like I said. It can be males as well, so we don't want to always count out males and just assume that they don't have it, because they do have it. It's just a lower percentage as of females, okay? Comorbidity with anorexia nervosa. More than 50% of people with anorexia nervosa have other concurrent psych disorder. It's usually associated most with anxiety disorders, or depression. Depression is usually about 65% of the time. So over half of the time, somebody has comorbid depression with anorexia nervosa. Keep that in mind, okay? So of course, they're at a high risk for suicide, you want to remember. And then the anxiety disorders we see are usually phobias, either social phobias or actually specific phobias. That's about 35% of the time. And then OCD is about 25% of the time. So that's pretty huge. Sexual abuse is more common in those with eating disorders than in the general population. I'm going to tell you from my experience, and this is my experience as a psych nurse for 15 plus years, okay? Now, I have never worked on an eating disorder unit, so don't get me wrong, I don't come into eating disorders constantly. We do get them on St. Clair occasionally, and usually it's the co-occurring disorder. Usually they're in for depression and they're like, oh, and they have anorexia nervosa. So we have to put in some of these interventions into play. I have known people that have worked on eating disorder clinics, okay? And from my experience as well, a lot of times when you start to talk to people with eating disorders, a huge number of them have a history of sexual abuse. Huge number. Abuse of any nature, but sexual abuse is pretty common. So I just tell you that to keep in mind, because that is something you really want to talk about in conversation with this patient as you develop that rapport. It's very, very important, because of course we need to get them help for that as well. Alrighty. So diagnostic criteria, this kind of changed in the DSM-5 a little bit, but I'll tell you kind of the big thing that changed. So restriction of energy intake, okay? They have to specify whether it's restricting type or binge eating, purging type, okay? With the binge eating type, okay, this is when, and we're going to talk about this in more detail when we get to bulimia. You see it more with somebody that has bulimia nervosa, but that doesn't mean that somebody that has anorexia nervosa can't have the binge eating type. Okay, I think that's just always something we've learned, that we think of bulimia more as binge eating and anorexia more than restricting. But I want you to know that they can have either type. Okay, we see either type in both. So that's something to definitely keep in mind. Okay, so restricting, of course, is they restrict all food. Okay, whereas binge eating and purging is where they binge. And we'll talk about the actual definition when we get under bulimia, okay? And then they purge either with laxatives, laxatives, with self-induced vomiting, of course. But a big one that we see with anorexia nervosa is they overexercise. So when I say overexercise, you know, we say people should exercise what, 30 minutes to an hour, 3 times a week. We're talking they usually exercise up to 4 hours a day. Okay, so that's definitely something when you're assessing the patient that you need to ask about. They have a fear of gaining weight or becoming fat, and then overall a distorted body image. With the new DSM, they do look at it by BMI, okay, or body mass index. And what does body mass index depend on? There's 2 things. Anybody able to tell me?
Height and weight.
Height and weight. Very good. Yes. So you can go in. I think your book has it. If not, you can actually Google BMI chart. Okay. And it will go into what BMI. For anorexia nervosa, now they actually have it broken down by mild, moderate, severe, extreme. Okay. Mild is when the BMI is still equal to or greater than 17, which is not a lot, y'all. If you go look at the BMI, like 17 really isn't a lot. Then there's moderate, severe, and extreme, and you can see the numbers there. Okay. They're also in your book. I do want to note this as well. Before the DSM-5, the central feature of anorexia nervosa was thought to be distorted body image. And I'm sure a lot of y'all heard that over and over again, right? Distorted body image. They have to have distorted body image. Now, although that's still an important criterion, they have decided that the drive for thinness, perfectionism, and fear of becoming fat is actually more essential to the diagnosis of anorexia. Okay, and your book talks about that, but I just kind of wanted to hone in on that. So what do we see when the patient comes in? Usually these patients, we're not going to see initially in an acute psych setting, right? They're going to be in the hospital. They're usually going to go to an ICU. Okay. So they're pretty sick puppies. Okay. So usually they're very underweight. They say less than 85%, very emaciated, amenorrhea, which means they usually don't have menses for at least 3 months in a row. Now, that used to be a criteria in the DSM for anorexia. They got rid of that now. We see it a lot because of the lack of nutrition, but they don't have to have amenorrhea to be diagnosed with it, okay? But we do normally see that. That is an assessment question that you would definitely want to talk to your patient about. Lanugo is pretty common. Does anybody know what lanugo is?
That's that hair, like the real fine hair.
Very, very good. Yes, it's what they call fine downy hair. I always think of a little new chicken or bird, you know, when they have their little feathers. But if you've ever seen babies, lots of times they have lanugo. Okay, and lanugo actually does serve a purpose. It actually keeps us warm. Okay, that's why babies get it a lot. It's to keep their body temperature warm inside. Okay, so same thing. This kind of happens. It's a part of our body protecting itself and trying to keep itself warm. Okay, so we do see lanugo, hypotension, of course, bradycardia. Everything just drops. You want to think of that. Everything drops. They don't have enough volume. So usually, of course, they're very dehydrated. We talked about hypothermia. We definitely see hypothermia a lot. I want to talk about peripheral edema. Can anybody tell me why peripheral edema would happen? Let's think about that third spacing.
I thought when I read in the book, they were saying that it was like that rebound fluid retention.
Okay. What usually happens when somebody third spaces, they usually have lack of this. Can anybody think about that? It's lack of albumin. Yeah, somebody just said that. Makes sense, right? So lack of albumin because they're not eating enough protein or anything of that nature. So what happens when you don't have that? Very good. So they end up starting the third space. So if you've ever seen anybody with anorexia, and if you do see them, they are sick puppies, okay? So they like need to be hospitalized immediately because they're probably close to dying. But it's very strange, and I've seen this a few times, and it wasn't even on my my acute psych setting. Like I said, it was on a different medical floors that I've been on. But I had this one patient one time. She had anorexia nervosa. Now, she actually had it because of a medical condition, but she was a sick puppy. And skin bones, I mean, she probably weighed 70 pounds, was probably 5'6", 5'7". So, I mean, she was a skeleton. She looked like she was 9 months pregnant. She had ascites so bad. She wasn't pregnant. It was the third spacing. And her ankles and her wrists were huge. So you see this tiny, tiny person, and they have these huge hands or huge ankles, or they look pregnant. And it's because they don't have enough albumin to keep that protein, to keep that fluid in the vascular space where it belongs. Okay, so it's the strangest thing when you see it, but when I tell you they're sick puppies, when you see that, like, you need to be extremely concerned, like screaming off the rooftops. Anemia, of course, hypokalemia. So we have to really be careful about that electrolyte imbalance because they're dehydrated. Pretty much everything goes down, right? They don't have enough. So what happens when people get hypokalemic? What do we have to look for? Heart problems, right? Arrhythmias, dysrhythmias. They're very fatigued. They don't have any energy. They start losing their hair, and that's because of the nutrition. Very weak muscles, and wasting of their muscles. If they do, we do see this sometimes if they purge, if they self-induce vomiting. But we see this a lot more with bulimia, but you can see it with anorexia. Like I said, if they self-induce vomit, they actually get chipmunk cheeks. Okay, same thing. So you have this person who has sunken eyes, and they are just like really, really thin, but they have these huge chipmunk cheeks, and it's due to the parotid glands. Okay, which is our saliva glands. Okay, they get blocked, and they cause the swelling of the cheeks, this hypertrophy of the parotid glands, and that's usually due to them getting clogged because they have self-induced vomiting for so long. Okay, of course, another constipation, things of that nature. So psychological, we're gonna hear them say things. They're terrified of gaining weight. Usually we find they're more perfectionists. We'll definitely see some of those cognitive distortions we've talked about, like with depression and things of that nature. They think they are so fat. They don't see that they're 75 pounds. Okay. They feel like they're so obese and overweight. Okay. You want to definitely talk about vomiting, how many times do they vomit a week, things of that nature. Laxative use, diuretics they'll use sometimes to control weight. And this is probably me just being very naive, but I remember this when I was younger, when I was in nursing school. Back in that day, I sound like an old lady, but back in that day, the Hollywood diet was very, that was the thing to do. And so like if you were going to the beach, you went and got the Hollywood diet at Walgreens, and all it was like a little bottle. I think they still have something like that, and people would take it and they'd lose like 8 pounds. Well, guess what? We know that's water weight, and we know that's not a safe way to lose weight. unfortunately, people have this disorder. Lots of times they'll use things like that to lose weight, and of course misuse it. So, of course you have problems with electrolytes and everything like that. Like I said, over exercising is definitely something that we want to watch for. They're usually preoccupied by food. That's all they want to talk about. Okay. And then, of course, we want to assess for the depression and anxiety, because we said that we see it so much co-occurring with these disorders. So nursing diagnosis, what would y'all think?
Disturbed body image.
Disturbed body image, very good.
Imbalanced nutrition, less than requirements.
Very good. Fluid volume deficit, good.
Risk for self-harm.
Risk for self-harm, good, good. And sometimes I would say self-injury, okay? Because lots of times, and it depends. Now, if they have depression and those kind of things going on, it's different. That's going to be more self-harm. But self-injury is going to be more if they're doing it not to hurt themselves, but they do end up injuring themselves in the end, if that makes sense. Electrolyte imbalance, I think somebody said that. Decreased cardiac output, because everything decreases, like I said. Chronic low self-esteem, knowledge deficit, ineffective coping. And then something we don't always acknowledge, but powerlessness and hopelessness definitely is going to play a role as well. Okay, so short-term goals. What do we want to see for our patient? Like I said, we want to keep them short-term, right? Especially somebody that's struggling with their weight. You want to keep that in mind. But they'll refrain from self-harm. Definitely safety, number one. That maybe they'll gain about a 1.5 pounds to 2 pounds a week. And sometimes this doesn't sound like a lot, especially when they're that thin. But this is sometimes too much for them to even take. So that would be one, that they would attain their normal cardiac functioning. And we're going to talk about more of that in a minute. Restoration of weight loss for more long-term, treating any psychological disturbances. This is definitely an illness of long-term. I said that anorexia doesn't last that long, like 1.5 years to about 1.5 years, but I'm going to tell you why. We talked about the death and things of that nature. This isn't going to a 3 to 5 day stay at a psych hospital and you're all better, right? Eating disorders are very specialized and need specialized care. I kind of hate it when we have an eating disorder patient, because I know that I can't give them the help that they need. Okay. That if it is, it's very my short-term goals, like I said, and it's more like watching them, making sure medically they're okay, those kind of things. But this treating psychological disturbances is huge. And we're talking years of therapy. Sometimes they do have treatment centers that are for a year, for a couple years. And anytime I see someone that has an eating disorder, that's the first thing I recommend is for them to go to a specialized care facility, because they really need it. This doesn't happen in a week or two. This is like a long-term treatment. And it reminds me a lot, and this is kind of why I keep it in the order I do in my class, but it reminds me of substance abuse in a way. And I'm going to kind of talk about that in a minute. And then, of course, overall, we want them to achieve long-term remission and or recovery. Of course, that's what we want to happen. Something I want you to keep in mind. Psychiatric interventions, just like I said, they take place after the patient is stable and they can absorb information. Just like our substance abuse patient, right? we need them to detox first. And they're going through so much physical stuff going on with their body. We need to make sure they're okay first before we get into the psychological. But it doesn't mean the psychological isn't important, because if they don't work on the psychological, usually they're not going to get better physically. So that's something you definitely want to keep in mind. Like I said, majority of these patients that have anorexia nervosa, they are in an ICU. They usually are so sick, that's where they need to be. So acute medical interventions are priority because they're safety, okay? So one of the biggest things that they're going to do is they're going to focus on refeeding and stabilizing the patient's health. Okay. Now we know lots of times these patients, they're not going to eat on their own. Okay. We can't get them to eat outside of the hospital on their own. So in the hospital, it's going to be a challenge. And rapport, gosh, is huge with these patients. And it's very hard to attain rapport. Okay. Why? Because they have this major problem and we're just telling them eat, eat, eat. That doesn't work. Just like if you told a patient with substance abuse, just stop using. What's your problem, right? It's not that easy. Not that easy at all. So with refeeding, we have to really, really be careful. So I'm going to describe what refeeding is. Refeeding is when they actually start a patient on so many calories a day. Usually someone with anorexia nervosa, they'll start them on like maybe 700 calories a day. We're talking low, but that's a lot of calories for them because usually they're not usually getting much more than 1,000 calories in a day, if that. So you start them slow. You start them low and you go slow, okay? So you start them just at a little bit, and then you're going to increase it until you get to the required daily intake, okay? Which it can be over time. Lots of times this is probably going to happen on a tube feed, okay? So, they're not just going to eat out of the blue, okay? Why do we have to refeed that slow? Overall, what we're doing is we're preventing them from dying, okay? If I were to give this patient somebody has anorexia nervosa for a year, and I were to give them 2,500 calories, I would probably kill them. And let me tell you why. So what happens is when you refeed somebody too quickly, it overwhelms the cardiovascular system because they're not used to having all of this in their system, right? They're not used to having so much protein, so much albumin, right? So many fluids. What ends up happening is they usually get pulmonary edema and they die of circulatory collapse. So you have to be really, really careful. And like I said, this is usually done in a very, very specialized setting, usually in the ICU, things of that nature. And usually it is done with like a feeding tube or something, a PEG tube or an NG tube, okay? Of course, you're going to meet resistance, like I said, too. So that's something. Alrighty, after they're stabilized, like I said earlier, they need a very structured milieu. Okay, so this is where, they need specialized care. It is too hard to have somebody in a setting like St. Clair, which is an acute adult setting, psych setting, but I have people that have schizophrenia. I have people that have substance abuse that are detoxing. I have major depressive patients. Might have psychotic patients, right? And then you throw in an eating disorder. You see how that doesn't work real well? You need people of the same, and we really find that with eating disorders, people really, they can grow from each other. Group therapy is really important here because lots of times from what I say, somebody that hasn't had an eating disorder, they're not going to develop the rapport that they will with somebody that has one and that they can relate to. Okay, so that's something to kind of keep in mind. So very structured milieu, therapeutic relationship is huge. Observation after meals and bathroom trips, like lots of times they'll lock their doors for so long after mealtime. And then if they have to go to the bathroom during that time, they're a 1-to-1 where somebody has to go with them and watch them. Of course, we're still looking for safety because depression is huge, right? Over 65% of people with anorexia nervosa. So keep that in mind. You do find a lot of manipulative behavior. And if y'all remember, we talked about manipulative behavior, especially last week with our substance abuse patients. It's something that over time they learn. And of course, in our society, we look at manipulation as bad, right? You know, if somebody manipulates you, you think they're a bad, hateful person usually. But it's something that they've learned through trying to get away with their disorder. So, of course, people that are abusing substances, just like an eating disorder, they usually hide it from people. They're not usually eating in front of people. You know, when they do eat, they eat alone. Things of that nature. Substance abuse, of course, they're going to be using alone or going to get it, that kind of thing. And in time, they have to lie about what they're doing. So that's where kind of the manipulation starts to take off, okay? And then they have lied so much by getting by with their disorder that in time it becomes a type of manipulation for survival, if you will. And they don't even always, they're not even aware that they're doing it sometimes. But it's very hard for family members and other friends, peers to actually deal with that sometimes. And then long-term cognitive therapy is really important. And they'll do behavioral therapy as well, but mostly cognitive therapy is what the social worker counselors are going to focus on with them more long-term. Okay. Medication-wise, there are no meds for eating disorders. There aren't. So, of course, we're going to treat what they have. And of course, you know, we talk about antidepressants. Why? Because I've said over and over how we see depression comorbidly with anorexia nervosa so much that lots of times they're going to be treating it with antidepressants. We have to be really careful here, though. What antidepressants do you think would be most commonly used? Can
SSRI.
Okay, yeah, we always say like SSRIs, right? Yes. Can anybody think of why SSRIs might not be the first choice here? What are some of our side effects? Okay, somebody said about serotonin syndrome, good. What about weight gain? Do you ever hear that a lot with, I hear this a lot with people that are, you know, sometimes my students' age, you know, saying that when someone usually is non-compliant with an SSRI and they're female, it's usually because of weight gain, right? Guys, it's usually sexual dysfunction. That's just usually what it is. So we have to really be careful here with weight gain. So I'm telling somebody who has an eating disorder, here's a pill, but it's probably going to make you gain weight. Do you think they're going to take it? No. So you have to be really, really careful how you teach them. Now, of course, occasionally there are a few SSRIs that actually can make some people, depending on their body chemistry, lose weight. But we don't want to tell them that either because then they might overtake it, right? So, so lots of times we just need to discuss with them that their weight can change. And if it does, they need to let us know one way or the other, okay, before they do anything about it. I will tell you, though, also age-wise, we look at, you know, what did I say? What was the average age here? About 16-ish, okay? What do we have to watch for with SSRIs? There's a huge side effect. It's actually suicidal ideations. It's huge in the adolescent population. And so that's definitely something we have to watch. So they're very usually cautious psychiatrists on giving an SSRI to someone under 18. Okay. So I will tell you now, like from my experience, usually on St. Clair, which is an adult care setting, we get people over 18. We see more SSRIs. But when I've gone to work on the adolescent unit, you don't see SSRIs like you do on the adult unit. Lots of them are going to be on TCAs or tricyclics. So I will tell you that that's something that you're probably going to see more of an anorexia nervosa patient being on a TCA. Okay. Also, periactin. Does anybody know what periactin is without Googling? Periactin actually stimulates the appetite. Okay, it's a type of antihistamine, and it makes you hungry. I know now, gosh, it's been a while since I've been on a medical floor, to tell you the truth, but I know back in my day when I was on the medical floor, like 10 years ago, Megace was kind of the drug of choice, like for cancer patients and things like that to stimulate appetite. Has anybody given Megace or periactin or anything like that? No. But they'll usually give them something to stimulate the appetite. Same thing. Do you think they're gonna be very resistant to this? Okay, most likely it will be going through an NG tube or a PEG tube, that kind of thing. But that is going to be definitely more short term. And then if we need some mood stabilization there, which is going to be maybe more irritability and aggression, then they will put them on an antipsychotic for that. Okay, usually short term, but it can happen because, like I said, the resistance is huge. What do you think is going to happen? Somebody puts in an NG tube, they're probably going to pull it out, right? So, there's a lot of issues there that we got to look at. Safety, like I said, anorexia nervosa has a high mortality rate. Okay, it is an illness long duration. It's, like I said, usually average can be a year and a half, and that sounds long, but it doesn't sound long compared to some of these other ones we've talked about, because usually, hopefully, they'll go through remission, okay, and they'll get better, or they're going to die. Okay, lots of times too, if they do start to go through remission, majority of our patients will start then with bulimia. So lots of times they switch from one eating disorder to the next, which really sucks, but we do see that happen a lot. We have to watch for binging and purging on the units, of course, electrolyte imbalance and things of that nature. And then also substance abuse is pretty common, especially alcohol. Does anybody know why? Ideas? We find that these patients with eating disorders, just like substance abuse, usually are very impulsive. Okay, so drug use, things like that, those are impulsive things. Okay, so I'm going to tell you a little story real quick, and then we'll take our little break. So there was a person one time that I was talking to, and her daughter had anorexia nervosa, and I just remember her telling me, like how thin her daughter was. She was like in the 70-pound arena, and she was at the time my age, and I was probably in my 30s, and I just couldn't even imagine, because even when I was thin, when I was younger, 70, I was not 70 pounds. So I can't even imagine. And this poor lady, we would talk, and it was very interesting because it was actually a support group for substance abuse. So you would think eating disorder, that's interesting. But she shared something one time, and it all came very clear and made sense to me. She said, I'm really struggling I know I'm enabling my daughter, but every time I come home from work, she wants me to pick her up an extra large daiquiri. And I'm thinking, a daiquiri? You know, I mean, gosh, we're talking about substance abuse here, you know? But this happened every day. And she said, and I do it. And she said, you know why I do it? And I kind of was like, no. And she's like, because I know that she's getting calories that day when I get her a daiquiri. And other days, I don't know how many calories she's getting. So I know that that keeps her alive sometimes. And to think about that, gosh, like that's like a harsh reality, right? I would have never thought that deep into it. So she struggled so much because she would get her the alcohol and she knew it would affect her, and that, you know, she was becoming an alcoholic. And the fact, I mean, she didn't have any weight on her. So to do an extra large daiquiri every day, it might not seem that big of a deal to some people, but for someone at 70 pounds, it is, right? And to think that her mother was thinking through the calorie intake, it just kind of blew my mind. So, like I said, you have to dig for that information. You're not always going to get that information from your patients. So it's definitely something we have to think about. All right, so it is 9:53. Let's come back about 10:05. Okay, and we'll wrap up. We'll talk about bulimia and wrap up there. All right, I'm gonna turn off this recording because last week I didn't, and I think y'all got the whole break, so I'm gonna stop it.